2 മിനിറ്റും കൂടെ വെയിറ്റ് ചെയ്യാം.
$7:30 ആയല്ലോ അല്ലേ?
2 മിനിറ്റ്. Yes, ma'am. Can we start? Okay.
So, good evening all. Welcome to the second talk of Dermatopathology webinar series, a general approach to inflammatory dermatosis. Approach to inflammatory dermatosis can be challenging due to diverse etiologies, similar histological features, and also limited exposure to dermatopathology during our residency program. So by combining the clinical information along with a systematic approach, we can effectively narrow down the diagnosis. So fortunately, we have the right person, right expertise to assist us in this process. And it is my immense pleasure and honor on behalf of IAPM Kerala chapter to introduce our distinguished speaker, Aravindan sir. We are so blessed to have Aravindan sir as our teacher, who's a constant pillar of support for all of us. Aravindan sir, formerly the professor and head of Department of Pathology at GMC Kozhikode, currently holds the position of a senior consultant at Kozhikode. Yes? Senior consultant at Kozhikode District Cooperative Hospital. Sir was a ICMR emeritus scientist at the Multidisciplinary Research Unit, GMC Kozhikode. Aravindan sir has been recognized with the Basu Malik Award for the best research work in 1996 by Indian Association of Pathologists and Microbiologists, especially for sir's work on acute appendicitis. He also received the Kerala Government Special Award in 2011 for implementing a comprehensive care program for patients with sickle cell anemia. Sir's notable contribution include extensive research projects in sickle cell disease in Wayanad district and acute appendicitis. Sir serves as a national editorial board member and reviewer for the Indian Journal of Pathology and Microbiology, and has been the past president of the International Academy of Pathology Indian Division. Additionally, Sir was a member of the SBMR, State Board of Medical Research, and an active participant in the Kerala Shastra Sahitya Parishad, a renowned people's science movement. Sir's areas of interest include evolutionary biology, methods of science, people science movement, ecology, and Sir is a lover of old Hindi film songs. With around 40 publications in both national and international journals and more than 20 presentations, Aravindan sir's contribution to the field of pathology is truly commendable. So over to you, sir.
Thank you, Shiny. I think I will directly go to the screen share without wasting any time. So this is what I'm going to talk about today, the general approach to inflammatory dermatosis. Human beings have been called the naked apes. In contrast to the other apes, like chimpanzees and orangutans and gorillas, we have literally virtually no hair at all. But it is only the last 10 to 20 years, 20 lakh years that this process of losing hair has actually started. In evolutionary terms, it's a very, very short period. And even now, we are really adjusting to that process of losing the hair. With the consequence that on the one hand, we have less of skin parasitic infections on the one hand because of this loss of hair. And on the other hand, we have a lot of other skin diseases because of the molecular changes, adaptations that have occurred in evolution. It's always a give and take. So we win some and lose some, as they say. So chronic inflammatory disease of the skin is one of the commonest diseases that we have around. Almost everybody has something or the other on the skin. And this is one of the least understood processes. The chronic inflammatory disease is probably, it is the next frontier in medicine because we are only beginning to understand the real processes within the chronic inflammatory disease. In this talk, I'm going to talk about dermatopathology in general and the approach to diagnosis of inflammatory disease. I won't talk about tumors at all. I won't talk about lymphomas, not about melanomas. And this part of dermatopathology is where the pathologists are more, they fear to tread this particular area. And primarily because of the huge number of diverse lesions. And so it is usually a validation or rejection of the clinical diagnosis that the dermatologist provides is the way that most people approach dermatopathology. Now, some of the special problems in inflammatory skin diseases is that the choice of lesion and the biopsy technique is important. I will show an example. And dermatologists tend to biopsy clinically atypical lesions. Please remember that. So with the result that the classical descriptions of a lesion you may not find in your slide because those will not be biopsied by the dermatologist. Lesions evolve microscopically. So at what stage this lesion is important, and that also has a bearing on the diagnosis. Then secondary changes, simple itching, scratching, everything can change the picture and confuse the picture. And lastly, there are too many entities and use of all kinds of archaic terminologies. All these make this field a little tricky, but with a systematic approach, dermatopathology is not really all that difficult. So this is a case of polyarthritis nodosa. Right beneath, deep down, you can see a vessel which is afflicted, and you saw inflammatory, a medium-sized vessel with inflammation. Now, initial punch biopsies taken did not reach this part, and so there was no diagnosis. It's only with a deeper elliptical incision biopsy that the diagnosis became possible. Now look at this. This is a bullous pemphigoid. Bullous pemphigoid, all of us know that this is a subepidermal lesion. But here what has happened? The bulla is above bit of the epidermis. What has happened is this is an older lesion has been biopsied. So this reepithelialization has occurred here and the bulla is above that. In this case, right side you see classical psoriasis. From the same patient, another area biopsy does not really look like psoriasis, only some features are there. So ideal biopsy where it should be taken is extremely important. See on the top left side, you see plenty of apoptotic keratinocytes in what is marked A. And on B, there is an ulcer. So area adjacent to an ulcer may show a lot of apoptotic keratinocytes. Just seeing so many apoptotic keratinocytes, you should not make a diagnosis, jump into a diagnosis of erythema multiforme or some such condition. Here, A shows a lot of leukocytoclasia. But no clinical picture of leukocytopenia, no palpable purpura or other features are there. And nearby is a follicle with acute inflammation. So acute inflammation and lot of neutrophils all around. And if there are a lot of neutrophils all around in the dermis, eventually they will all die out and you will see leukocytopenia. So this is what happens in this case. And this is a prurigo nodularis. It may be mistaken for psoriasis because of the psoriasis form hyperplasia, and impetiginization, that is repeated scratching, may produce infections and you may get an acute inflammatory accident. This may be mistaken for psoriasis form, neutrophils in psoriasis. So the steps primarily in diagnosis is you go by the reaction patterns first, then the finer points in differential diagnosis. First, you say that, okay, this is this reaction pattern. Then you go to the finer points in differential diagnosis. And of course, clinical information, extremely important. Without a proper clinical information, you should never make a dermatological diagnosis. Then, if needed, the special investigations, particularly immunofluorescence, invesicular bullous, and vasculitic lesions, sometimes immunohistochemistry, not so much in inflammatory lesion, more in tumors. Molecular techniques, particularly in certain kinds of infections. The pathologist and dermatologist should frequently interact, and it should not be a very, very distant communication, but a close interaction is absolutely essential. So these are the reaction patterns that I'm going to discuss, and I will rapidly run through some of the important conditions within this, and then just give a list of few conditions. It's not exhaustive at all, just to get you a feel of what the way to approach a inflammatory skin disorder. So these are the reaction patterns that I'm going to discuss. 10 reaction patterns. First, the spongiotic pattern. Okay, so this is, all of you can appreciate that this is spongiosis. This is edema in the epidermis, and it separates the cells. And in between, intercellular edema separates out the cells. And frequently, you find few lymphocytes in that area. That is called exolymphocyte, exocytosis. And there may be inflammation within the in the dermis. And there are many conditions which can give rise to spongiotic pattern of disease. Allergic contact dermatitis, irritant contact dermatitis, atopic dermatitis. And these are some of the most common skin conditions. If you take about roughly between 5 to 10% of the population in the world are affected by some or other of these conditions sometime or the other. So this is a typical, what they call as eczematous lesion. A typical eczematous lesion. You find spongiosis here. So you know that this is a spongiotic dermatitis. So instead of just calling out that this is a spongiotic dermatitis, can you go further? Are there further clues to narrow down to some or the other of the types? In this particular case, you see the right side, you find this area of spongiosis. You find a rather well-defined area of loose with some cells around here. And if you see closely, this is a collection of Langerhans cells. So when you find a spongiotic, all around you find spongiosis. So you find a spongiotic dermatitis with collections of Langerhans cells, then you know that this is probably an allergic contact dermatitis, and you can ask for a history of contact allergy, and there'll be some or the other kind of contact allergies. In all kinds of spongiotic dermatitis, it's really important to know the contact and with various substances. And increasingly in our environment, you have so many substances, soaps and detergents, and in addition to that, natural causes like many plants, plant products. Now, plant products in the form of herbal ointments and various kinds of herbal remedies. Then this is a blister beetle. It can produce, all these can produce spongiotic dermatitis, sometimes very, very strong kind of reaction. And this is called the irritant contact dermatitis. Because of direct contact to this material, you can get irritant contact allergy, and this is what it is, the appearance. And here you find more of a vacuolization and lot of apoptotic keratinocytes, and when you see such a picture, always ask for the history of any irritant substances. So this is just a list of spongiotic dermatitis, atopic. So there are, each of them may have some clues which help you to point out to one diagnosis. So there are atopic dermatitis, for example. There may be eosinophils and follicular spongiosis. Allergic contact dermatitis and Langerhans cells. Pityriasis rosea, there may be parakeratotic scale of these spongiosis. And each of these may have some or the other. Miliaria, you can find sweat duct and acrosyringeal spongiosis and neutrophils in that area. So there might be many clues, and you should look for such clues after narrowing down to one particular pattern of diagnosis. Now, second pattern is the psoriasiform pattern of disease. So here two questions that you ask. Psoriasis is an extremely common disorder. So is it psoriasis? And if it is no, your answer is no, it doesn't seem to be psoriasis vulgaris, then you say what it is. That is the question that you ask next. So this is the classic psoriasis that you find here. And psoriasiform hyperplasia, long, thin, reti ridges, which are almost of a similar length. And this is the typical psoriasiform hyperplasia. Many conditions can produce psoriasiform hyperplasia. Then parakeratosis. Parakeratosis is extremely important. So without parakeratosis, do not diagnose an active psoriasis. It cannot be an active psoriasis if there is no parakeratosis. And of course, the presence of neutrophils is the confirming sign. It may be there in the corneal layer or in the spinous layer in the form of spongiform pustules that you see here. Spongiform pustules of Kogoj, it is called. Dermatologists are very fond of giving names to all diseases, but now the names are too much to remember, so they're slowly phasing out and giving out the other kinds of names. So these are the spongiform pustules. So this is a classic. And suprapapillary thinning. Usually you always see the suprapapillary epidermis is thin here. So that is also a helpful sign. Many other conditions with spongiform, psoriasiform hyperplasia, you may not find this thin suprapapillary area. So this is classic spongiosis. Now here, there is a sort of spongiotic dermatitis here. There is some parakeratosis, a few neutrophils here and there. In many such cases, it is extremely important that you look for fungal organisms. Here you find a fungi when it is stained with GMS. So very clearly seen. And without special stain, sometimes you may really miss dermatophytes. So it's important in possibly all such cases, suspicious cases, to do this fungal. Be liberal with the special stains, PAS or GMS. And this is another example of a condition that clinically may mimic psoriasis, and it may even show psoriasiform hyperplasia and parakeratosis, but frequently parakeratosis may alternate with areas of orthokeratosis. This is pityriasis rubra pilaris. So here are some of the psoriasiform conditions. Dermatophytes, pityriasis rubra pilaris, pityriasis rosea, lichen simplex chronicus, and seborrheic dermatitis. Okay, I won't go into the details of all of this. Each of them may have a clue to the diagnosis. Like for seborrheic keratosis, there may be follicular, around the follicular ostia, there may be parakeratosis, follicular lipping it is called. So such clues may be there in each of these. You can read up that. Now, interface pattern of interface dermatitis. You can broadly classify interface dermatitis into lichenoid and vacuolar type of interface dermatitis. Now, lichenoid, pathologists say lichenoid when you find a infiltrate close to the epidermis which obscures the epidermodermal border. That is lichenoid for us. But for the dermatologist, lichenoid means clinically appearing like lichenified, lichen that is seen on tree barks. So lichen appearance like on the tree barks. That is lichenoid for them. So both the terms we use differently. So, and other is vacuolar interface dermatitis, where you find vacuolar change in the basal cells, basal vacuolar degeneration. So this is the typical lichenoid infiltrate, where the dermo-epidermal junction is really not seen. Basal cells are hardly seen. You cannot see the basal cell layer nicely beneath the epidermis. There are few apoptotic keratinocytes, heavy infiltrate in the upper dermis. Almost, this is called the band-like infiltrate. This is classical lichen planus. It is a lichenoid interface dermatitis in lichen planus. You see apoptotic keratinocytes here, some pigment incontinence. There are very many variants of a lichen planus. If there is a lot of epidermal hyperplasia, it is hypertrophic lichen planus. Sometimes it may be so much that you may even suspect, is it pseudoepidermatocyte, is it squamous cell carcinoma in some places. Indeed, squamous cell carcinoma can rarely arise from these lichen planus lesions. Then this is one papillae is broadened, and you find a very well demarcated infiltrate within that. And some epithelioid-like histiocytes also can be seen. This is lichen nitidus, the classical lesion. Then in lichenoid infiltrates, if you find plenty of eosinophils, it's always good to ask for history of drug eruptions. Many drugs can produce drug reactions, particularly of the lichenoid type. So lichenoid drug eruption is another differential you should look for. Always look for eosinophils. If there are plenty of eosinophils, it's quite likely that there is a drug behind it. And when you find a lichenoid infiltrate, along with the psoriasiform hyperplasia, maybe a little spongiosis here or there, but a psoriasiform pattern and this lichenoid infiltrate. Pityriasis lichenoides chronica is a possibility always to be thought of. Okay, so this is the second type of interface dermatitis that we were talking about. Here, look at the basal layer. You find that many cells are ballooned out, containing a lot of hydropic degeneration or vacuolar degeneration. And in addition, here you find the basement membrane material, which is very pink in color. It is thickened. A thickened basement membrane material, some pigment incontinence. Pigment incontinence always indicates that there has been some basal layer damage. Basal layer damage produces melanocytes to drop off and melanin to be seen in the superficial dermis. So this is an interface dermatitis with vacuolar kind of change and this thick basement membrane material. And of course, in such cases, of course, with clinical history also is important. You have to test for lupus. And frequently, this is acute or subacute. Lupus erythematosus can present in this manner. Another condition where you can get a lot of vacuolar degeneration here, along with many apoptotic keratinocytes. See, you can see a lot of apoptotic keratinocytes all around, even in not just in the basal layer, even above, and vacuolar degeneration. And here you find apoptotic keratinocytes around the sweat duct. See, this is the acrosyringium. And around the acrosyringium, you find apoptotic keratinocytes. This is classical of erythema multiforme. So that is another condition which can produce this change. And this is a list of interface pattern that which you can see in lichenoid. Many conditions are there. Vacuolar, apart from SLE and erythema multiforme, Stevens-Johnson syndrome, toxic epidermal lytic necrosis, then acute GVH reaction can pityriasis, early forms of pityriasis lichenoids. All these may produce a interface, vacuolar interface pattern. Fourth is the perivascular pattern. Now, these are the kind of biopsies that I'm sure that many of you get. it'll come with all kinds of diagnoses. When you look at it, you find just a few lymphocytes around some vessels. You really do not know to call it normal skin, or even normal skin, you will find the occasional lymphocyte here and there. So is it normal or something? So this pattern is, if you can't really make out anything further, just say that this is a superficial perivascular dermatitis. And this kind of mild picture with very few lymphocytic infiltrate can be seen in some other conditions. Like this one, you find a little bit of perivascular infiltrate and some little edema. And clinically, if it fits in well with this picture of red erythematous lesion, then it may be an urticaria. Urticaria and urticarial vasculitis, sometimes you find the neutrophils may be seen, occasional leukocytocracia and neutrophils within this, but otherwise a mild kind of picture. And clinical history is really very important. Urticaria is a lesion that really resolves within about 24 hours. Urticarial vasculitis may go on for some more time. So history is again very important. Post-inflammatory hyperpigmentations. All that you see will be a little superficial perivascular dermatitis, and some pigment cells will be there here and there. And if you ask a history, you will know that there has been some skin disease some time back, and maybe this is just a remnant of that and some pigmentation, again, which may be a very mild change. This lesion, on the other hand, there's much more of inflammatory infiltrate. It is superficial perivascular areas are affected indeed, but much heavier and very cleanly demarcated, very sharp kind of infiltrates, what you call a coat sleeve infiltrate, this is called. And if you ask the history, you'll find that usually this will be an annular lesion with a margin that is spreading, and this is typical of a erythema annulare centrifugum, EAC lesions give this kind of a picture. Sometimes you may find a little spongiosis. It may be there is a superficial and a deep variety of this particular condition. This was a case that we once got of multiple small papular and slightly raised papular lesions all over the body, occurring as almost like an eruption. And there were again this perivascular infiltrates, very sharp, almost looking like EAC, but it contained plenty of plasma cells. So when you find a lot of plasma cells, EAC, you find lymphocytes, the lymphocyte infiltrate. When you find plenty of plasma cells, always look for syphilis. And in this particular case, it was secondary syphilis, all the antibodies were positive. So that's another condition that you, of course, it is rarer now than before, but always be on guard when you see plasma cells. And this is a partial list of perivascular dermatitis. Superficial and deep, mobiliform drug eruption, viral exanthemes. Sometimes many viral diseases, all that you may see is just a perivascular lymphocytic infiltrate. Pigmented purpuric dermatosis. All that you may see is along with hemosiderin pigment, all that you will see is only superficial perivascular infiltrate. Now coming to the next is nodular and diffuse infiltrates. Nodular and diffuse infiltrates may be nodular and diffuse, of course, or diffuse, and it may be granulomatous or non-granulomatous. And non-granulomatous may be mainly lymphocytes, mainly neutrophils, or mainly eosinophils. So when you see some dermal infiltrates, like this one, for example. So this lesion, I'm sorry I can't interact and ask questions. I would love to actually interact in such cases, and get feedback. So here what you find, this sharply demarcated plaque-like lesion. Okay, there may be other histories are also obviously it will be present, and you find very long, a normal epidermis and elongated granulomas, long granulomas, almost as if it is following a nerve. a neurovascular bundle and following a nerve, very long, and it is granulomatous. So this is a granulomatous. So this is very classical of Hansen's disease. And this is Hansen's disease, borderline tuberculoid. The classical granulomatous lesion, once very, very, very common, but now fortunately much rarer now than before. Though there seems to be slight recrudescence of this disease in the recent times. This is another granulomatous lesion, multiple granulomas, but again with a normal epidermis. See, look at this, epidermis is normal. Multiple granulomas, and you can find frequently some giant cells. Some of them may contain calcific bodies, and this is cutaneous sarcoidosis. So sarcoid and Hansen are two conditions where you find a normal epidermis and large epithelioid granulomas. Here you find a lesion where it's not epithelioid granulomas, but plenty of histiocytes in between collagen. And there is some collagen degeneration, sharply defined collagenous. These are the kind of granulomas which are called necrobiotic granulomas. And this is the classical appearance of a granuloma annulare lesion. Now, here the main difference is that again you find granulomas, but you also find the epidermis is reacting. And the epidermis shows pseudoepitheliomatous hyperplasia, very reactive kind of epidermis. You find giant cells, granulomas. Two conditions produce this kind of lesions. One is tuberculosis, particularly nowadays, atypical mycobacteria, and also chromoblastomycosis. And this was granulomas you see along with neutrophils in the center, those so-called pyogranulomas, and you find the copper penny bodies of chromoblastomycosis. And heavy lymphoid infiltrates, perivascular lymphoid infiltrates. Of course, always your problem is it a lymphoma or is it a benign lymphoid hyperplasia? So immunohistochemistry may help, and usually frequently both T cells and B cells may be present. Sometimes in benign cutaneous hyperplasia, you may find lymphoid follicles may be present with staining with B cells. And some of them may be associated with borrelial infections, though I have not personally seen. I've seen marginal zone kind of proliferation, but of course we could never really link it to a borrelial infection. So cutaneous lymphoid hyperplasia is another condition that produces this heavy dermal infiltrate. That is lymphocytic infiltrate. Now here comes a lesion where there is a edema in the subepidermal region is very edematous, and the infiltrate is all full of neutrophils. And this is the classical appearance that you see in Sweet syndrome. And this is a case in which you find plenty of eosinophils in the infiltrate. And in between you find this very eosinophilic areas. These are composed of eosinophil granules, and these are called flame figures. This is a case of eosinophilic cellulitis or Wells syndrome. Another condition in which again you can find lot of dermal infiltrate along with plenty of eosinophils is insect bite reactions. This is arthropod assault reactions or insect bite reactions or papular urticarias, they are also called. Plenty of eosinophils are again seen. And so dermal infiltrates can be granulomatous or non-granulomatous, and the non-granulomatous can be lymphocytic, neutrophilic, or eosinophilic. Each of them you find different conditions, entities within this. Again, clinical picture is important. Sweet syndrome and pyoderma gangrenosum, some areas may look exactly the same. So you want to know the exact clinical picture. Some infections or abscesses may be there. Near an abscess, you will find plenty of neutrophils looking like Sweet syndrome. Unless you know the clinical picture, you may not be able to make a diagnosis. Now, next is follicular and perifollicular patterns of inflammations. And folliculitis can be infectious, eosinophilic, infectious diseases, eosinophilic folliculitis, or perforating folliculitis group of conditions. And alopecias, now frequently you get the biopsies for alopecias are much more frequent than what used to be in my older days at least. And alopecias can be generally classified into scarring, divided into scarring and non-scarring alopecias. See this case, you find a follicle and inflammation around the follicle. Sorry. You find inflammation around the follicle here, going really deep into this. And when you look at the follicle, you find that there are plenty of, it is packed with yeast bodies. Yeast forms, no hyphae. And this is the typical endothrix infection of Tinea capitis. So this is an infection by a fungal organism producing a pattern of alopecia. In this case, again, you find a parasite here. You can see the demodex. Multiple demodex are seen in the follicles, and the follicles are also inflamed. So in such cases, maybe it is the demodex that is producing an inflammatory reaction, and you may be justified in such cases in calling it demodex folliculitis, though demodex always will not produce inflammation. It may be just a commensal organism, just seen in many biopsies with very clean, lying just cleanly within many follicles. But in this case, at least, there seems to be a folliculitis and too many, numerous demodex all around. In this case, you find a follicle and inflammation all around. And here, it seems to be almost ulcerated. And if you ask the history, there will be history that there is some material is getting extruded out. And history similar to that is perforating folliculitis. And this goes along with other perforating disorders of the skin, many of them associated with diabetes, like Kyle's disease, where follicle is involved. Sometimes even without the follicle involved, there may be collagenoses, perforating collagenoses, perforating elastosis, and so also. So special stains will be helpful in such cases. Coming to alopecias. So this is the typical scarring alopecias where you find no hair follicles, just scars, linear scars like this. And sometimes you cannot make any particular diagnosis. You just call it an end-stage scarring alopecia. Beyond that, you may not be able to make any diagnosis. Sometimes you can make a diagnosis, like in this case. Here you find a follicle and you find around the follicle almost a lichenoid kind of infiltrate. And this is classical of lichen planopilaris, which is one of the common causes of a scarring alopecia. And in this case, there is no scarring. Plenty of follicles are there, no scars are found. And you find more of this telogen and the less of anagen follicles, more of the telogen and catagen follicles, and inflammation. Inflammation just around, all around, and sometimes it will be likened to a swarm of bees. And this is a typical appearance of alopecia areata, a case of non-scarring alopecia. This is another case of non-scarring alopecia. It can present as a small nodule. Sometimes it may be hypopigment. In many cases, I've seen used to come with diagnosis of Hansen's. I don't know how it resembles Hansen. In literature, it doesn't really mention that. But in our cases, at least, sometimes they say it comes with a diagnosis of Hansen's. And you find these follicles will contain mucinous kind of change. And this is follicular mucinosis. And it can be associated with alopecia. And follicular mucinosis, one thing to remember is that follicular mucinosis can sometimes be associated with follicular mycosis fungoids. There may be a heavy lymphoid infiltrate associated with that. Typical epidermotropic porphyria abscess and typical follicular kind of infiltrate, in which case you will have to do the immunohistochemistry to really look for it. In this case, of course, doesn't seem to be so. So this is a follicular mucinosis. And this is a list of follicular and perifollicular lesions. Folliculitis may be infectious, eosinophilic perforating, as I said. Infection can be fungal, bacterial, viral. Then scarring and non-scarring. Two of the common scarring alopecias are lichen planus and DLE. And pseudopelade is another cause, which is an end-stage kind of look it has. Non-scarring alopecias, of course, alopecia areata and androgenetic alopecias are the common ones. Coming to vesiculobullous lesion, I'll just go through because there I believe there's a full session on vesiculobullous lesions to come up along with immunofluorescence. Vesiculobullous lesion, immunofluorescence findings are always needed, and it is very important. So basically, you can divide them into subcorneal, depending upon the location of the bulla. It may be subcorneal, intraspinous, suprabasal, or subepidermal. Just let us see examples of each of these. This is a subcorneal bulla, just corneal layer, and above that there is a pustule. So this is subcorneal pustular dermatosis. Many other conditions can mimic a similar picture, like bullous impetigo, staphylococcal infections. So in which you may find bacterial colonies within this, which may be better brought out by Gram stain. So subcorneal lesions, you can divide it like this. Scanned inflammation, maybe pemphigus foliaceus is a possibility. Then if you find neutrophils, bullous impetigo, IgA pemphigus, and the generalized pustulosis, eosinophils, incontinentia pigmentae, erythema toxicum neonatorum. These are all subcorneal lesions. Now, this is a bulla within the spinous layer. And this hyper picture is a giveaway. You find giant cells with ground glass nuclei, multiple nuclei with ground glass appearance. So this is typical viral vesicle. This was the case of herpes zoster. Intraspinous bullae, you find lymphohistiocytic bullae. In spongiotic disorders, you can find bullous kind of appearance in many spongiotic disorders. Incontinentia pigmentae, eosinophils, neutrophils in impetigo, ballooning in viral blisters, and acantholytic lesion. All conditions under suprabasal, which we'll discuss next, you can get acantholytic lesions, maybe sometimes intraspinous also. This is the typical suprabasal bullae. In all such cases, this acantholysis, see these cells loosely separated from each other, lying singly, and the basal layers are just sticking out, and again separated from each other. Very important to do the immunofluorescence. Direct immunofluorescence shows the fishnet appearance, so-called intercellular fluorescence. IgG3 maybe will be present. So this is pemphigus vulgaris. Two other conditions where you get the suprabasal clefting or bullae is diarrhea disease. Diarrhea disease you find in addition to this acantholysis, suprabasal acantholysis, this dyskeratosis. You find dyskeratotic lesions, plenty of keratin. And Haley disease, you find larger areas of acantholysis, sometimes giving what is called a dilapidated brick appearance. These are all classical lesions, but sometimes this can occur in other type of lesions also. So these are the DDs of suprabasal bullae: scant inflammation, diarrhea disease, Haley, eosinophils in pemphigus vulgaris, vegetans, and paraneoplastic pemphigus. So this is subepidermal bullae. you find the subepidermal bullae, and you find plenty of eosinophils within the bullae fluid, and the linear immunofluorescence, IgG and C3, usually producing this lesion in subepidermal bullae. So this is bullous pemphigoid. This is another case of subepidermal bullae, but in this case, mainly in the papillary epidermis, you find neutrophils. And along with this neutrophils, if you do the immunofluorescence, you find IgA deposition. And this is classical of dermatitis herpetiformis. And these are the DDs of subepidermal bullae: scanned inflammation, eosinophils as in bullous pemphigoid, neutrophils as in dermatitis herpetiformis, and lymphocytes may be seen in bullous lichen planus or bullous erythema multiforme may appear as bullae sometimes. Now comes the fibrosing lesions. This is the most common, possibly among the fibrosing lesions, a very common lesion. You find fibrosis going right deep into the subcutaneous tissue, sometimes with a border that is very sharp, sharply demarcated below, and less of appendages all around. Appendages seem to be pulled up, and this is the classical appearance of morphia, and the same appearance you can get provided the clinical history fits in systemic sclerosis, where you have to do the antibodies and other testing. Another fibrosing lesion where you get a very thick corneal layer. The keratin layer is very thick, sometimes even thicker than the epidermis, and the superficial area particularly is very sclerosed. And this is the classical appearance of lichen sclerosis. Used to be called lichen sclerosis at atrophicus, but now lichen sclerosis is quite good enough. And these lesions, early lesions, can appear very much like a lichen planus with ballooning degeneration, sometimes the degeneration of the basal layer and so on. This is another fibrosing lesion, very classical appearance, neck and upper back. You can get thickened skin. And if you look at you find a lot of fibrotic skin with spaces in between the thick collagen fibers, and mucin may be present sometimes. And this is the typical appearances of what is called sclerodema. So these are the list of fibrosing lesions, predominantly affecting papillary dermis, predominantly affecting reticular dermis. Fibrosing conditions with mucin, like sclerodema and scleromyxedema. Conditions affecting subcutaneous and deep tissue, like in eosinophilic fasciitis and erythema myalgia syndrome. I don't have cases of that. The next is vasculitis. Again, this is it's a condition where you need immunofluorescence and other tests frequently to make a correct diagnosis. Typically, this is a lesion what is known as the palpable purpurus. And this palpable purpurus, and you do the biopsy, you find neutrophils as well as nuclear dust, which is typical, and this is called what you call as leukocytoclastic vasculitis. When you find a lesion like this, then you do a direct immunofluorescence and to see what kind of antibody is deposited there. If it is an IgA antibody, it is a IgA vasculitis or hinox-Schondlin purpura. Sometimes you may not get this. So, typical lesions of hinox-Schondlin purpura, the antibody deposition may not last much longer. After about 48 hours, it may disappear. So you may get sometimes a negative immunofluorescence after a particular period. So it's important to biopsy the early lesions. So this is the same case, and you find perivascular IgA deposits in these cases. So this was an IG vasculitis occurring only in purpura. This is another case where small vessels are affected, but also medium-sized vessels are affected. And you have such cases, when you find medium and small vessel vasculitis together, it is important to ask for the clinical history. Are there any lung lesions? And important to do an ANCA testing to know whether it is a polyangiitis, microscopic or granulomatous polyangiitis lesions, or eosinophilic polyangiitis lesions, or the so-called Churg-Strauss syndrome. So this was a microscopic polyangiitis with small thrombi and small vessels, when larger vessels also affected by the lesion. And this was ANCA positive. This is yet another case of what is known as a vasculopathy, rather than a vasculitis, because there's no active inflammation. But here you find plenty of thrombi, dilated vessels, capillary vessels with thrombi, multiple thrombi, and you find this thrombi. IgM is frequently positive. Fibrin is also usually positive. And this is livedoid vasculopathy or atrophy blanche. Both are interchangeably used depending upon the clinical appearance. And this is not a very uncommon disease, frequently occurring in the legs. This is a description of the vasculitis: small vessel, small and medium vessel vasculitis, and vasculopathic lesions, various kinds of diseases that can occur. In all of this, workup is extremely important. You have to do ANCA, other antibodies, autoimmune workup. Everything has to be done in these cases. And lastly, I come to the last section of paniculitis, or inflammation of the paniculus. Here you find these are nodular lesions occurring in the legs, being the history. You find a septal kind of paniculitis. Of course, there is a vessel around which there is some meniscus, and all around in the septa. So this is what is called a septal paniculitis. Sorry. Okay, I will return the diagnosis. That was erythema nodosum. And this is again a vasculitis and vascular involvement, and granulomas are also seen. And this pattern is known as the lobular paniculitis. Not the septa, but right within the lobule, you find infiltrate. And this is a lobular paniculitis. And this is erythema induratum, or otherwise nodular vasculitis, sometimes associated with tuberculous kind of lesions. And TB, PCR may be positive in many cases. This is another somewhat frequent skin condition which occurs along with varicose veins and venous disorders. You find lower legs being predominantly involved. You get pigmented plaque-like lesions, and frequently painful also. And you find inflammation both in the dermis, deep dermis, and as well as the paniculus. You find thickened vessels. And this has some overlap with stasis dermatitis, and plenty of hemosiderin vessels, pigment being deposited, thickened vessels, and sometimes fat can show a peculiar appearance of what is known as a membranous kind of fat necrosis. This kind of appearance is typical of lipodermatosclerosis. Frequently overlooked kind of condition, but now more and more biopsies of lipodermatosclerosis are coming to us now. So this is the summary of paniculitis, predominantly septal and predominantly lobular. Erythema nodosum, erythema induratum are the classical lesions in each variety, and you find other conditions. Lupus can sometimes present as primarily as a paniculitis, lupus paniculitis, In such cases, the presence of mucin in the dermis may be a helpful clue to diagnosis of lupus, and dermatomyositis also sometimes can produce that. Okay, I think this is my last slide, and I finished in time, I think. Thank you very much.
Thank you so much, sir. Dr. Shiny, can we take a couple of questions which we have in a chat box?
Yes. So one question is, can LCV be negative in DIF, biopsied early lesion?
Which one?
Can LCV be negative, leukocytoclastic vasculitis, be negative in DIF?
Yeah, we do get such, even the so-called early lesion, what they say is early lesions, also sometimes we get negative lesion. But then you have to really look at it and see whether they have really biopsied the right area, whether there are other lesions like infections or infectious abscesses or other cellulitis around and things like that. It's sometimes difficult. It's sometimes a very difficult problem. When you get a negative DIF, then it is a problem sometimes.
Okay, sir. Next question is, what should be the diagnosis in cases with minimal lymphocytic perivasculitis without any other findings?
Minimal
lymphocytic perivasculitis.
Yeah, depending on the clinical history. If there is just a lymphocytic vasculitis, then it may be a viral infection or some other condition. It's very difficult to give a pinpoint and give a diagnosis in such case. Depends heavily on the morbilliform drug eruptions may be one of the causes. So depends again on the clinical picture.
Okay, any other questions? You can either type in the chat box or can ask directly. You can raise your hands. Okay, sir. Points to differentiate scleromyxedema and scleroderma. Scleroderma.
Mucin and also scleroderma, you don't find mucin. That is one thing. Clinical distribution will be different. And scleroderma, particularly SS, systemic sclerosis, it has a very typical clinical picture. It has a particular immunoprofile if you do the autoimmune scan and so on.
Any more questions?
All cases, it's very fine when your clinical diagnosis and dermatology, your pathologist diagnosis, are same or very similar, then it is quite okay. But when it is widely different, you always have to rethink, are we making a mistake? Either the dermatologist or the pathologist will have to rethink and come to a consensus. It's very, very important.
Okay, I think no more questions. Dr. Deepa.
There are no more questions.
Yes.
Any more questions?
Yes. What are the characteristic microscopic features in skin seen in dermatomyositis?
Dermatomyositis, it can be quite a varied kind of picture right from it may look just like SLE to paniculitis like lesions. So it's a there's nothing very specific for dermatomyositis to call something a dermatomyositis. It's heavily dependent on the clinical picture and the other accompanying things. but it can resemble SLE in many ways. When you find an autoimmune kind of picture similar to SLE, and you find all the SLE markers being negative, always look for NA profile to look for dermatomyositis. And male patients. SLE, almost always it's a female patient, except rarely.
Sir, a question. So is the dyskeratosis seen in Darius disease same as that seen in other conditions?
Other conditions, I didn't understand what.
Pre-malignant dysplasia.
No, it's not dysplastic. Dysplasia, dyskeratosis, the appearance is very different in the sense that Darius disease, you find single cells, single cells are small grains or small rounded cells, what are known as chorons. These are single kind of cells, not the classical pearls and other things that you find in tumorous lesions. So it's quite different.
So then one question, how to differentiate lichen planus bulla and pemphigoides bullae?
Immunofluorescence would be the ideal way. Linear immunofluorescence should give you, because lichen planus will, DIF will never give a linear fluorescence. It's only granular fluorescence, frequently IgM, not others. And eosinophils in bullous pemphigoid will be almost, without eosinophils, I would be very suspicious of making a diagnosis of bullous pemphigoid.
Is lupus band test specific for lupus?
No, specific thing is antibody testing. Antibody testing, particularly the now, of course, very sophisticated profiling tests are available now. It's much easier to do that straight away in any case that you suspect an autoimmune disease. Much better to straight away do a profile.
So if you have any questions, you can raise your hand and type in chat box. Okay, I think it's over. Dr. Deepa.
Thank you, Dr. Shaini. Sir, on behalf of the IAPM Kerala chapter, I take this opportunity to thank our esteemed speaker of the day, dear Aravindan sir, for the highly informative session on inflammatory dermatosis, which is a very vast and tough area, dermatopathology. So has tried to incorporate almost all lesions. And thank you, sir, for the lucid presentation. And we feel that everybody will be benefited by this session, and more PGs will be interested in dermatopathology. And we also thank our dear members for their active participation today. And we would also like to thank Mindray India team for providing the platform and the assistance for the smooth conduct of the webinar series. And before concluding, a gentle reminder, our next webinar is on the next Friday, 7:30 p.m. That is on January 17. And the topic is General Approach to Vesiculobullous Lesions of Skin by Dr. Raghavendra Rao, Professor, Department of Dermatology, KMC, Manipal. Thank you all and good night.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you, everyone.